All right, so welcome to First Aid AMC Clinical free 2 week session again. I am Dr. Arshan, as you already aware. Now, tonight's session is going to focus on cardiology, right? So we did a cardiology first session with you a few days ago, and we had our initial cluster, which was syncope cluster. And you guys had an idea that how to use a single history and physical examination format to use like maybe in 6 or 7 cases we have done last time, right? So that's how we normally do our cluster-wise approaches, and that's usually our theory sessions. Most of the theory session will be like that. So tonight is also another theory session, which is about some of the other important cluster for cardiology. One of them is palpitation cluster and another is chest pain cluster. Both of them are very, very important for your exam. So as always, what we are normally doing in here that we will keep your mic muted for the class. So if you want to ask any questions, feel free to write it in the chat box in Zoom. And those of you who are in Facebook, you can also write it in your comment section. Those of you who are new to our free 2 week session, just to give you an idea that we are taking our 5 months AMC clinical course. It has started on 11th of December. So you haven't missed quite a lot of classes so far. We have done like psychiatry MSc with a role play of that. That was 2 trial sessions that we have taken. One was on 12th of November, another was 30th of November. So if you have missed it, make sure you go through the recordings. Recordings are available in our Facebook group and also in the YouTube. If you don't find it, you can always inbox me and I will show you the right way. Okay. And other one is we did our cardiology session. We also had a random role play session with Dr. Cynthia. So that was all the classes that we had so far. This is a part of our 2 weeks free session at the moment. The schedule of those 2 week session is already given in the First Aid AMC Clinical Facebook group. So just follow that, join like how you have joined today, and you can get an idea how AMC Clinical examination preparation should be. Okay, all good. So let's start our class tonight. We will do cardiology theory session 2 today. So the cluster that we are going to do is called palpitation or nervousness cluster. So as always, when we do some cluster, we start with our differential diagnosis. So what are the differential diagnoses of palpitation? We have CVS related cause, CNS related cause, endocrine causes. So in case of CVS, it can be any of the CVS related causes like ischemic heart disease, myocardial infarction, even sometimes hypertension, arrhythmia. Any of the arrhythmia can present to you with palpitation, especially for exam purpose, SVT, atrial fibrillation, atrial flutter. Those are very important. And sometimes valvular heart disease, not too much important, but arrhythmia, MI, ISD, those are very important. For CNS causes, stroke or transient ischemic attack, epilepsy, infection, trauma. You remember our CNS differential diagnoses are always same. So trauma, tumor, infection, head injury, and stroke, right? So you can get it here, trauma. Tumor is not very important, but infection, TIA or stroke, and epilepsy is our causes. Very important to rule out is the endocrine causes, which is hyperthyroidism, hypoglycemia, and pheochromocytoma. Anemia can present to you as palpitation. Anxiety disorder is very, very important to rule out because many times it can be just a psychological stress which is bringing on the palpitation or nervousness. So rule out anxiety disorder, panic, or any stress. Sometimes perimenopause can also present as palpitation or nervousness. There is one very important case for exam where patient present to you like a 47-year-old woman coming to you with feeling nervousness or feeling like a palpitation, night sweats, did not say hot flushes or something like that. That is supposed to be coming from you, but they will just come to you as feeling nervous, weird, unusual, and that's the time you think about perimenopausal phase. Excess tea, coffee, or recreational drug also should be ruled out. Excess coffee, tea can also precipitate SVT. So try to rule that out in any palpitation. Medication induced. Tell me one medication which is notorious to give you palpitation. Anyone? Yes, very good. Dr. Sovia, Dr. Nguyen, Ventolin or salbutamol, right? So it's a very commonly used medication in Australia, and many patients can present to you with palpitation after taking too much Ventolin. So those are all the important differential diagnoses for palpitation. Moving on to our history. Remember in our initial session, the cardiology part 1, we did discuss how to start your history. So make sure you remember that and follow the same approach here. And you also might remember that there are different approach for face-to-face and online examination. Okay, so tonight we are not going into that much of a detail like we have done in our previous session. If you are new, then make sure you go through our first session so that you have an idea. But when you start something like this, like a patient with palpitation will present to you within the day or maybe the next day. So it will be an acute presentation, right? For any acute presentation, you should make sure that patient is vitally stable before you start their history. So let's say how we are going to start this one. So let's say the patient name is Sam. So hi Sam, this is Dr. Arshan, one of the doctor in this clinic. It's very nice to meet you. I understand from the notes that you are having palpitations or racing of your heart. I'm very sorry to hear that, but now that you are here, we are going to take care of you. But before I ask you any further question, please let me ensure you are vitally stable. So I'll just talk to my examiner and come back to you. Is that okay with you? Yes, doctor, that's fine. Well, examiner, I would like to know if my patient vitally stable for further history. If examiner says stable, then you move on and just talk with the patient. If examiner asks you, what do you mean? Then you will need to ask the detailed vitals from examiner. So examiner, can I get the blood pressure and pulse with rate and rhythm? Rate and rhythm is very important because F is your one of the DD here. So for atrial fibrillation, you can get irregular rhythm, right? So don't forget that. And then just ask the other three: respiratory rate, temperature, and oxygen saturation. Once you have got the vitals, turn your chair towards the patient and then say, thank you so much for waiting, Sam. Now that I am sure that you are vitally stable, would you please tell me a little bit more about this racing of the heart? So always we start with a open-ended question. So would you please tell me a little bit more about it? Patient will give you the every excuse me guys, just 1 second. So patient will give you everything that he was supposed to give it to you if you ask an open-ended question. If not, then you might lose some important information. So patient will say that, yes, doctor, I was just jogging in the street and then suddenly I started to get racing of the heart. So that means you already know from the patient's history that when did it start, right? It started when he was jogging. And what exactly were you doing at that time? You also got answer for that. Now, it depends what information you get from the patient, but otherwise you will need to find these whole questionnaires from the patient. So we need to know, when did it start? Did it start suddenly or gradually? What exactly were you doing at that time? Is it for the first time? Most of the patient will not present to you in the first time. So they will have some previous episodes. Now you will need to ask the detail of those previous episodes as well. So ask the patient, so no doctor, this is not the first time, it happened for the third time. So can you tell me a little bit more about those 3 other episodes? How did it happen? How did it finish? what exactly did you do at those times. So just get an idea that which situation brings this palpitation on. So that's a very important thing to do. You need to also find out anything makes it better, anything makes it worse. Is it continuous or on and off? And how long each of those episodes last? Okay, so that's your history of presenting complaint, which is palpitation. The medical jargon is palpitation, but if you want to use a simple word for palpitation, that's a racing of the heart. Along with the racing of your heart, you also need to find out some associated symptom. In the associated symptom, you will be able to rule out all the serious differential diagnosis. So ask the patient, so along with palpitation, during these episodes, do you also feel dizzy or lightheadedness? Many times patient will feel dizzy with any of the arrhythmia, any chest pain, difficulty breathing, any nausea, vomiting, or excessive sweating. Why we are asking this? To rule out myocardial infarction. Any headache, any problem with your vision or your speech. Now, these are your CNS differentials. So headache, any problem with vision or speech, any weakness, or any loss of consciousness. So we are actually asking all the differentials anyway, CVS and CNS related here, okay? Once you have asked the CVS, CNS, GD, then you move for other differential diagnosis, endocrine. So for hyperthyroidism, any change in your weather preference, any change in your bowel habit, any change in your body weight. So patient with hyperthyroidism, they will feel very hot and sweaty. Even though it's a cold weather, the patient will feel very hot and sweaty. So that's why we are asking, have you noticed any recent change in your weather preference? If patient does not understand weather preference, then you will just need to short it out like, well, do you feel very hot and sweaty even though it's a cold weather? Okay. Sometimes patient asks, what do you mean? In that case, you just need to explain it, what actually you are trying to ask. Any change in your bowel habits. So hyperthyroidism patient will have diarrhea and also they will lose weight. If you ask them, have you noticed any change in your appetite? Patient will say, yes, my appetite has increased, but still I am not gaining any weight. So that's hyperthyroidism. For each of the differential diagnosis, usually two questions is at least a good idea. So 2 or 3 questions for each of the differential. For pheochromocytoma, any episodic headache, sweating, or flushing of the face. So patient with pheochromocytoma, they get a paroxysmal attack of throbbing headache, sweating, and flushing of the face. And they also get a episodic hypertension. So that's your pheochromocytoma. Never ever have seen this pheochromocytoma coming in the exam, but still you should rule out. Hypoglycemia. So when this palpitation happens, do you usually skip your meal before that? So we need to also find out that does hypoglycemia has anything to do with this palpitation? Okay. Then for anemia, how's your daily diet? Do you take a healthy balanced diet, or do you feel very tired and fatigued these days? For infection, any fever, cough, runny nose. Always remember, any recent flu-like illness can cause palpitation. Like anyone who is febrile, it can cause tachycardia, right? So just ask that, are you feeling sick these days? Any fever, any cough, any runny nose, or any other flu-like illness? Rule out any electrolyte imbalance that can also give palpitation. So any recent heavy vomiting or diarrhea. After that, we are just finishing with the same thing, past medical history, SADMA, family history. And don't forget to ask about any stress. So even before this SADMA, past medical and family history, ask the social history. So for social history, you're trying to rule out the possibility of anxiety causing this nervousness or palpitation. Usually, we try to give some confidentiality before we ask this question. So we ask the patient, so I'm going to ask you some personal questions, but please be aware that these are confidential between you and me. So Sam, who do you live with at home? Everything all right at home, or is there any stress at home? Are you working at the moment? Yes, doctor. Where do you work? Any stress at your work? Okay. Any financial issues? And are you are you normally an anxious person, or do you worry a lot about most of the trivial things? So that's to rule out generalized anxiety disorder. Patient with GAD, they usually have a like a excessive worriness or anxiety about everything. So that's why we ask that, do you think you are an anxious person, or do you worry a lot about most of the trivial things? So that will rule out any of the psychiatric causes. If the patient is a female, especially around menopause, then don't forget to ask them menopausal symptoms. So ask the patient, when was your last menstrual period? Is it regular or irregular? And then ask about menopausal symptoms. Have you noticed that you're getting sleeping problem? You're having mood swings these days? Any hot flushes? Okay. Any muscle aches and pains? Any problem with your bowel or bladder? So patient with perimenopausal phase, the most important findings are hot flushes, then night sweat, palpitation, then all other things like muscle aches and pains, urinary difficulties, or urinary incontinence. They can also have sleeping difficulty, getting very irritated and anxious all the time. They can also have palpitation. They can also have little bit of joint pain. So you don't need to go in detail, but at least ask about hot flush, irritability, and also about night sweats. Okay, so that will be your perimenopausal symptoms. And lastly, finish with SADMA, past medical history and family history. For SADMA, you just ask, do you smoke or drink alcohol? Any other recreational drugs? How about tea and coffee? We need to find out how much of tea and coffee this guy is drinking. Many Australian drink 8 to 10 cup of coffee. So that's not something which we recommend. Regular patient can have 2 drinks of coffee in a day. That's healthy, but 8 cup is always not a good idea. Okay, so tea, coffee, that's what we should ask in palpitation cluster, because a lot of time in the exam you will get it positive finding. Ask about any other past medical condition, like any diabetes, high blood pressure, or heart condition, any family history of sudden heart related death or sudden cardiac death. So those are the important questions we are going to ask in here. So that will give you the finishing of this palpitation history. So to give you a summary, first of all, you reassure the patient, you make sure patient is vitally stable, then ask about the presenting complaint, which is palpitation, ask in detail, and then ask about all the differential CVS, CNS, endocrine, which include hyperthyroidism, pheochromocytoma, hypoglycemia. Ask about miscellaneous like anemia, infection, electrolyte imbalance. Don't forget to ask about social history. And lastly, finish with SADMA, past medical history and family history. Okay. And if it's like above 45-year-old female, don't forget to ask about menopausal symptoms. Okay. So that's history. Moving on to physical examination. Physical examination is exactly similar like the previous class. Okay, so you will start with general appearance, then you will ask about pickled vitals and BMI. You will do the neck, CVS like before, and then CNS especially. Because CNS is one of your differential diagnosis, you will just say, I would like to do full central nervous system, including the cranial nerves. And lastly, say you would like to do all other systemic examination and then office test. I'm not discussing this physical examination again because we have already done in our last session. If any of you missed it, please make sure you first go through our first class on cardiology for this. That's our format for nervousness or palpitation cluster. Do you guys have any question? If not, then we will move to the cages. Anything that you haven't understand? All good? Great. Moving on to our next topic, which is now we have done our cluster format and we also know the physical examination. Let's move on to the cages. The important exam cages are supraventricular tachycardia, atrial fibrillation, or flutter. So we're going to do both of those. So supraventricular tachycardia. You are a junior HMO in emergency department. A man came in with thumping or racing of the heart and giddiness, which has started today. Your task is to take a history from the patient, physical examination from examiner, ask investigation from examiner, and explain your diagnosis to the patient. So this is how usually the questions will appear in the exam, especially for this kind of cases. When you see 4 tasks like this in the exam, you will have to be very quick in your task because it is very difficult to finish 4 tasks in exam. But time to time, there will be 4 tasks, but most of the time it's 2 to 3 tasks. But fewer cages will have tasks like this. The important thing to remember that 4 tasks is usually, you will struggle to finish it in 8 minutes. So be very fast from the start. The positive points in here, so you'll just take the history like we have done. So you already know that you're going to ask about palpitation. You will also ask about lightheadedness or giddiness. Now, giddiness is also your presenting complaint. So just add in our history of presenting complaint. First, you will ask about racing of the heart, the whole questions that you have just seen. And then you will ask about little bit about giddiness. So can you tell me a little bit more about this giddiness? Did it start at the same time when you started to have the thumping of the heart? Do you feel giddy all the time, or is there any particular time or situation? Okay, do you feel giddy when you change your position? Do you feel giddy or lightheadedness when you move your head? Also, please explain that, do you think like you are also having a feeling like the room is spinning around you, or you are spinning around the room? Just to rule out the possibility of any vertigo. So a couple of questions from lightheadedness you can ask, okay? Not too much. After that, you will ask the whole other differential diagnosis question like you have done in the history format. You will get the positive finding that patient having palpitation and lightheadedness since 2 hours, also feeling a little bit of short of breath. Previous 3 episodes started suddenly, lasted 2 hours, and then stopped all of a sudden. Patient takes 6 to 8 cups of coffee a day. So that's an important finding. No smoking or alcohol, no previous or family history of heart condition. Patient is also quite anxious personality and having some stress ongoing. You can see that a lot of things can be found in a person, and your diagnosis should focus on the whole history, physical examination, and the investigation. So everything will lead you to the exact diagnosis, not just a single thing. Like if the patient say, I am very anxious all the time, but in the ECG you can see SVT, and if you say that it's most likely anxiety disorder causing this palpitation, that's wrong. Patient can be anxious, but he still can get a SVT. Okay, so your diagnosis should focus on everything, just not a single point. Now, this is a ECG which was given. So you did your history, you did your physical examination from examiner. Your third task was ask investigation from examiner, and you asked for a ECG from examiner. Then examiner showed you this ECG. Now, most of the time what happens in exam that ask investigation from examiner, they also add another task and explain ECG to examiner. That's usually the task. When investigation like a ECG is given in the exam, they also ask you to explain the ECG to the examiner. That's a tricky thing to do because you don't have a lot of time in the exam. In that time, you will need to read the ECG and also explain it. The good thing is that you don't need to know a whole range of ECG for AMC clinical examination. Like in MCQ, you had to go through a lot of ECG, right? But for clinical, just a few ECG, if you know, that should be fine. Because exam usually will not give you a ventricular tachycardia or ventricular fibrillation patient. They usually will give you SVT, atrial flutter fibrillation, maybe sometimes WBW syndrome. I haven't seen though, but usual cases are just these two, SVT and atrial fibrillation or flutter. Okay, so and also we did our prolonged QT syndrome. That's also another important ECG for exam. Now let's say you have got a ECG like this. What are you going to do? When you get a ECG like this, first of all, you already know that this patient most likely having some arrhythmia just by the look of the question and the history. So where you should look at first, always look at the long lead for any arrhythmia related problem. So in the long lead, you can see, if you look at here, all the RR interval, those are regular, right? So RR interval regular, which means rhythm regular. The next thing you look at each of the waves. So you do remember that one ECG should have a P wave, then, sorry. Hang on a second. Right? So a ECG should have a P wave followed by QRS complex and then a ST wave, right? So P, Q, R, ST. That should be your normal ECG component. But if you look at here, so this is your QRS complex followed by T wave. So where is the P wave? There is no P wave here, right? So loss of P wave. Then if you look at the QRS complex, normal QRS complex is at least 1 to 3 small square. If you look at this QRS complex, it's not even 1 small square. That's what we call as narrow complex tachycardia, okay, or narrow QRS complex. So you have got a narrow QRS complex and ST wave is fine, right? Because you can see the T wave properly and there is no ST elevation. So that's what you have got here. You have got loss of P wave. You have got a narrow QRS complex. There is no ST elevation and T wave is normal. How we know that is it a tachycardia or not? Because normally, if you look at here, there is only, you can say that 5 plus 3, 8 small square in here. Same in here, 5 plus 3. So that means it's a regular rhythm, right? If you don't need to be very sure about the heart rate in the exam, just a little bit of the approximate heart rate, if you can say, you should be fine. So heart rate is obviously increased. How we measure heart rate? Number of large square in between two RR interval. So large square in between two RR interval divided by 300. Sorry, 300 divided by number of large square in between two RR interval. Now let's say in here, for the purpose of our less time consumption, let's just say it's one large square. That means the heart rate is around 300. So if you are smart, you will say that it's in between 250 to 300, right? If there was two large square, what would be the heart rate in here? 150, right? If there was three large square, the heart rate would be 100, right? So that means if there is three large square in between two RR interval, the heart rate will be increased. More than three large square means heart rate is normal, right? So that's the easy way. to remember in the exam, and you can just say that how much is the heart rate. So if you look at a ECG and you can see two large square in between two RR interval, you can just say that the heart rate is around 150. If you can say that, you are fine. Obviously, this is only applicable if the rhythm is regular. Like in atrial fibrillation, where the RR interval is not regularly placed, in those cases, you can't say the heart rate that easily. In those situations, just say heart rate is increased. You don't need to say how much is the heart rate, because it is very difficult in that time to say that how much is the heart rate for a atrial fibrillation patient. But for others where you have got a regular RR interval, you can actually say what is the heart rate just by remembering this formula. Okay, so that's how you should just find out the findings in ECG. Now remember one thing, that when you look at a ECG, it should be very smart in the exam. Like if a patient comes to you with a chest pain, you should look at the V1 to V6 first, because those are the chest lead and you can get some finding here. We will come to that cluster and then you will see how we are going to read those ECG findings. But for palpitation, you will look at the long lead, which is the lead 2 usually, and just think about how is the P wave, how is the QRS complex, how is the ST wave, what is the T wave. Okay, so just have a look and you will always find out the findings. In supraventricular tachycardia, so that's how it usually looks like. You will get a narrow complex tachycardia. So that's tachycardia, you can see narrow complex QRS. You will get the T wave, but no P wave. Now, this is how you're going to explain ECG to the examiner. So you will say that, dear examiner, I would like to describe the 12 lead ECG of my patient, John, a 25 years old gentleman who presented with a sudden onset palpitation and giddiness. The ECG shows heart rate about 150 beat per minute, but this patient, which we have done, it's around 250, you can say. So heart rate around 250 beat per minute, regular in rhythm, absence of P wave, narrow QRS complex, no ST wave changes, T wave normal in size and shape, and QT interval normal as well. Which means when you present ECG to an examiner, you have to talk about each and every component of it. So you first start with rate and rhythm, then you talk about P wave, QRS complex, ST wave, T wave, and lastly, QT interval. Okay, is this clear, guys? Good. So explain to the patient. So after you have done your ECG explanation to the examiner, you will turn to the patient and say, thank you so much for waiting, John. Now, you remember that we have done an electrocardiogram of your heart. And that's when the nurse put those leads on your chest. The lines that you can see here are the result of electrical impulse that conduct in your heart. Let me draw a picture for your better understanding. So this is your heart. The electrical impulse, so you can say here. So this is your heart. The electrical impulse originates from here and then goes all over the heart to pump the blood to your body. In your case, there is some abnormality in these electrical impulses, causing your heart to beat faster than normal. And you can say here that most likely the abnormal impulse is coming up from this part of your heart. That's why, because your heart is beating, you are having this racing of your heart, and because your heart is not getting enough time to fill in, your brain is also not getting enough blood supply, which is causing the giddiness or lightheadedness that you are having. Together, we call this condition as supraventricular tachycardia. So that's how you can make it very simple for the patient. In a lot of notes, in lot of other areas, you will see how difficult they have written the explanation of this kind of arrhythmia. Patient does not need to know what is P wave. Patient does not bother what is ST wave. Patient does not need to know what is tachycardia. The patient needs to know why I am feeling this racing of the heart. Patient needs to know why I'm feeling giddiness. That's the only two things patient actually wants to know or care about. So you will have to correlate your explanation of the condition with the patient's symptom. So that's where a lot of candidates make it wrong. They think that they're just teaching a medical student. The patient is not a medical student. He or she never ever seen a ECG in their life. So how come they will bother about what's in the ECG? Okay, so never ever even try to show that, look, this is the ECG, that's your P wave, that's your ST wave. It's totally nonsense. There is no need of that. The important thing is that if a patient can understand the simple thing that this is my heart has 4 chambers, and this ECG that the nurse has done is the electrical impulses that conduct in my heart. So then you can just explain that this is your heart, this is the upper chamber, and that's your lower chamber. The electrical impulse from here and then goes all over your heart, which helps the heart to pump blood to our body. In your case, there is some abnormality in this electrical impulse, which is most likely originating from the upper chamber of your heart. Because of that, your heart is beating faster than normal. And that's the reason why you are having this racing of the heart. Because the heart is pumping faster, it's not getting enough time to fill in. As it's not filling in, it's also not providing enough blood supply to your brain. And that's why you are feeling this giddiness or lightheadedness. We call this condition as supraventricular tachycardia. Are you with me so far? Do you understand what I said? Yes, doctor. Now, there could be many reasons behind it. Like you can say that it can be due to some structural heart disease or valve-related problem, can be related to some medication, recreational drug intake, thyroid dysfunction, sometimes infection, salt or mineral imbalance, or excessive tea coffee intake. In your case, what I am suspecting that because you have been drinking 6 to 8 cups of coffee in a day, that might be one of the trigger as well. So what I would recommend you to limit your coffee intake to 2 cups in a day, please. Okay, apart from that, this kind of racing of the heart or giddiness can be due to other condition. Then you can give all other differential diagnosis if you want. Now, again, you already talked about differential diagnosis here as well. So what I would suggest that first explain supraventricular tachycardia in detail like this, and then say that there could be many reasons behind it, like maybe some damage to the heart or a structural defect of the heart, valve-related problem. But in your case, I'm suspecting because of excess coffee of 6 to 8 cups, it is most likely the triggering of this condition. Okay, sometimes it can even happen without any known reasons. So what we are going to do is to do some investigations to rule out all the important causes of your palpitations. Apart from that, some other conditions can also cause palpitations, like if you have some hormone-related disturbance, like thyroid dysfunction, diabetes or low blood sugar, if you are having a condition called pheochromocytoma, but you don't have any symptoms related to that. Sometimes it can be due to anemia or low hemoglobin in your blood, but you are having healthy balanced diet. You don't look tired or fatigued these days. It can be infection induced, but you don't have any fever, any runny nose or any other flu-like illness. So just give some differential diagnosis. Okay. So that will be your supraventricular tachycardia case. Now, usually management does not come in exam for this kind of cases. But if it comes, what are you going to do? So usually supraventricular tachycardia, the first thing that we always make sure if the patient is vitally stable or not. If patient is vitally stable, which means that blood pressure is normal, patient is not having any shortness of breath, patient is not confused or not having any chest pain. So that means if patient is mainly stable, then usually initially you can start with some vagal stimulation or some, like you can start with Valsalva maneuver. So any of those like carotid massage, Valsalva maneuver, even sometimes immersion of the face in a cold water, any of those are fine. So you can initially you can say that first of all, non-medication or conservative treatment is the usual choice. So what I'm going to do is to ask you a maneuver called Valsalva maneuver, where you will need to pinch your nose by your fingers. Okay, take a deep breath in from your mouth and then breathe out through your ear. So first of all, pinch the nose by finger and then deep breath from the mouth and breathing out from the ear. And that's what we call as Valsalva maneuver. Carotid massage is usually not the first line anymore, only in the emergency department with the specialist or with the register available as a junior doctor, you can do it. But just start with the Valsalva maneuver. You can talk about carotid massage or any other vagal nerve stimulations. If those measures does not help, the next option is medication, which is IV adenosine. IV adenosine can be repeated a couple of times. If it's not helping, the last option will be DC cardioversion. Okay, as I say that it never comes in exam as a management, but if it comes, you just need to know stepwise approach. So patient will be admitted in the hospital. They will have a ECG again. They will have regular blood tests. So the same blood test, full blood count, liver function, kidney function, thyroid function, lipid profile, blood sugar level, all the regular ones, and also urine microscopic culture to rule out any infection. So once you have done that, you can also order an echocardiogram of the heart to rule out any structural or valvular heart disease. The treatment depends on the stability of the patient. If vitally stable, then you will start with the Valsalva maneuver, then medication, then lastly DC cardioversion. If patient unstable, first option will be DC cardioversion. If patient asks you if there is any cure of this condition, yes, if a patient get it for multiple times, it's affecting their lifestyle, then and also quite not manageable with medications, then yes, sometimes they can offer a radio frequency ablation where all these impulse that's originating from the heart, it can be destroyed. So that's the curative options for recurrent SVT. Okay, so if in the exam it comes, you can just talk about it. Otherwise, don't bother too much about it because already it's 4 tasks. So there is not much of a time for management. That's why they don't usually give it in the exam. Any question with the supraventricular tachycardia? Now, in online examination, there is usually a medical student on the other side. Not always, Dr. Numra. There are cases where you will just need to talk with the role player. Not always there will be a medical student on the other side. Only in physical examination, you can get a medical student in online exam. It's totally same in online examination as well. You will just talk with a patient over a video. So nothing is different. It's just the mode of examination which is different. All right, moving on to the next case, atrial fibrillation. A middle-aged lady comes to the ED with sudden onset palpitation. Task is history, physical examination, investigation from examiner. Now, this is another kind of question. Explain causes and complication of the condition. So you need to find out what is the diagnosis and also the cause and complication of the condition. So the positive point in the history will be same. So more or less same thing. You can get like patient was maybe running or maybe not doing anything, but it still has ended up getting a palpitation or racing of the heart. So follow the same approach of history and physical examination. And this will be your ECG. In the ECG of atrial fibrillation, the findings that you mainly look for is that if you look at the long lead 2, you can see that it's an irregular rhythm. So that's 1 RR interval, and look at this RR interval. So it's obvious that it's an irregular rhythm, right? So you have got an irregular rhythm. Heart rate, you can't measure heart rate in here like this. So it's a difficult thing to measure heart rate in a atrial fibrillation patient, which for the purpose of exam, you don't need it at all. We can explain it, but it will not be useful in the exam because you don't have that much time to find out how much large square is there in 25 beats or in 30 beats and then multiply by 10. It's not needed. So forget about it. Just say that the heart rate is increased. After that, we look at the P wave. In atrial fibrillation, the P wave will be replaced by some fibrillatory wave like this. So you'll not be able to find out the exact P wave, but you will see some of the fibrillatory wave like this. So that's what you have got here. Then you can get a narrow complex sometimes, but sometimes just a normal QRS complex, and others will be fine. So T wave, ST wave, everything will be fine. The only finding in atrial fibrillation we'll be looking for is the heart rate increase, rhythm irregular, P wave replaced by some fibrillatory wave. That's the usual findings. So explain the ECG that I would like to describe a 12-lead ECG of my patient, Mr. John, who is a 25-year-old patient coming with sudden onset palpitation. The ECG shows heart rate. Now in here, you'll just say that heart rate is elevated, irregular in rhythm, absence of P wave, which is replaced by fibrillatory F wave, narrow QRS complex. It depends. Narrow QRS complex means if it is less than 1 small square. If you see that the QRS complex is 1 to 3 small square, it's normal QRS. No ST wave changes, T wave normal in size and shape, QT interval normal as well. So that's your finding for atrial fibrillation. Very easy to find out in the exam. Now explain to the patient what is the diagnosis. Now the good thing about it is that SVT and atrial fibrillation, the explanation is same, because basically they are having the same kind of thing. One, that heart is beating faster regularly. Another is heart is beating faster with an irregular pattern. That's the only difference in the explanation. Otherwise, it's totally same. So you can just say in here, if you look at our explanation, so you'll just say that from the history, physical examination, and the ECG, I'm suspecting you are having a condition called atrial fibrillation. So let me explain in detail. So remember when the nurse put those leads on your chest, that's the time we did an electrocardiogram of your heart. The lines that you can see here are the result of electrical impulse that conduct in your heart. Let me draw a picture for your better understanding. So then you will say same thing, this is your heart. The electrical impulse originates from here, goes all over the heart to pump the blood. In your case, there is some abnormality in this electrical impulse. Especially, there is some abnormal electrical impulse originating from the upper chamber of your heart, and your heart is beating faster than normal and also with an irregular chaotic pattern. That's why you are having this racing of the heart, and your heart is not getting enough time to fill in. That's why your brain is not getting enough blood and you are feeling dizziness. Same. See that it becomes so easy. Just with one explanation, you can deal with the two cases. And then you will say that there might be a lot of reasons why someone can get this condition, like if you have high blood pressure, if you have any heart condition like a heart attack, any coronary artery disease, which is the blood pipe that supply your heart, abnormal heart valves, heart defects that you are born with, an overactive thyroid gland, exposure to some stimulant like medication, excess coffee, alcohol, or smoking, sometimes some lung condition, previous heart surgery, viral infection, and stress. And sometimes atrial fibrillation can happen without any known reason, known as lone atrial fibrillation. So in your case, I am suspecting that most likely you have high blood pressure, and that might be the reason why you have got it. But still, we will do further investigation to rule out any of these causes. So that's the cause of atrial fibrillation. In this case, you can get patient is hypertensive. Then you can just explain that this is most likely the reason. Now, this condition sometimes can be serious, especially the chaotic rhythm may cause blood to pool in your heart upper chamber, and it can result in formation of clots. If a blood clot form, it could also dislodge from your heart and travel to your brain, which can block your blood flow of the brain, causing stroke. On the other hand, in atrial fibrillation, especially if it is not well controlled, it can weak your heart and lead to heart failure, a condition in which your heart cannot circulate enough blood to meet your body's need. But please don't get scared about it. It's very good that you are here, and now we know what you are having, and we can manage your symptoms. And with appropriate medication, most of the time we can prevent these complications. So always remember one thing: if you say something life-threatening or like a very scary thing to a patient, just immediately talk about that this can be manageable. If it is actually manageable, then say that it is manageable with appropriate medication. You will be fine. All good? So that's the complications that usually you need to know. Now, again, this atrial fibrillation does not come with management. I have seen though, like maybe once or twice, but not a usual thing. If management comes, again, the same thing, the patient obviously need to be admitted in the hospital. So if you're in a GP setting, send the patient to the hospital through an ambulance. And then in the hospital, they will be admitted, will be seen by the cardiologist, and further investigations will be done. Investigation, the basic blood test will always be done. And then also they might want to do an echocardiogram of the heart to find out the heart function. The further management depends on the stability of the patient. If patient is vitally stable, then in atrial fibrillation, the management is either you control the heart rate or control the heart rhythm. To control the heart rate, any of the heart rate blockers like beta blocker or calcium channel blocker will be the first choice. The usual choice is metoprolol or atenolol. That's the beta blocker. If beta blocker contraindicated, then we can go for some calcium channel blocker like diltiazem or verapamil, which are the rate limiting calcium channel blocker. If rate controllers does not help, the next option is rhythm control. To control the rhythm, the usual medication that is given in Australia is either sotalol, flecainide, or at the end, the last option might be amiodarone. So any of the antiarrhythmic drugs can be tried. Still after that, if the atrial fibrillation is not well controlled, the option would be DC cardioversion. Okay? If patient is unstable, the first option is DC cardioversion. When you get a patient with atrial fibrillation, the management is just not managing the symptom, but also to prevent the complication, which is a stroke or any of the emboli related complication. So to find out if a patient is at high risk of having a stroke, we use the CHEST-VASc2 score. And CHEST-VASc score will lead you to think that does this patient need any prophylactic medication to prevent this stroke complication? Okay, so how we actually do those CHEST-VASc score, let me just open from the Google. Just hang on a second. So that's the CHETS VUSC scoring system. We'll give you a good picture later on, that's fine. So normally, the CHETS VUSC score, if a patient has got C for heart failure, congestive cardiac failure, so a score of 1, H for hypertension, 1 point, A is more than 72, so that's why A 2, so 2 point. D for diabetes, another S2 is for stroke or TIA, 2 point. Any vascular disease like a peripheral vascular disease, 1 point. A is more 65 to 74, 1 point, and S for sex, which is female, 1 point. Okay, so CHETS VUSC scoring system is the system that will lead you to find out if a patient needs anticoagulant to prevent this embolism. So now basically that we say that if the score is 0, there is no need for any anticoagulations. If the score is 1, it's actually a tricky area. Like you can consider giving anticoagulant, it's case by case. But if it is more than equal to 2, that patient will require anticoagulants. Now, nowadays, we no longer just give warfarin to everyone. Previously, we used to do that. Nowadays, the guideline is that if you need to give anticoagulant to a patient, find out that if it is a valvular heart condition causing the AF. So if it's a valvular AF or patient having a mechanical prosthetic valve, like aortic valve replacement, any of the valve replacement patients, those patients will need warfarin, lifelong warfarin. That's the only kind of patient who needs warfarin nowadays as a prophylaxis. For all other patients, like a non-valvular AF, let's say a patient who has hypertension, who also have diabetes, okay, that patient got 2 point and also got AF. That patient will be a non-valvular AF. Those patients will get NOACs. NOACs are newer oral anticoagulant, which does not need regular INR checkup like warfarin. That's why this is a more preferred anticoagulant these days. And NOAC includes any of those, like you can talk about rivaroxaban, apixaban, or dabigatran. These are the commonly 3 medications. Before giving NOAC, we just need to make sure patient's kidney is fine. So if it is a kidney failure patient, you will not be able to give NOACs. But as long as their kidney function is fine, you can give them NOAC. So usually for those patients, you can continue a maintenance dose of rivaroxaban or apixaban. That will be the management for any of the atrial fibrillation patient as a prevention of complication. Okay, so that's usually the important thing. When a management of AF come in exam, it's a whole thing. So you'll need to talk about what is AF. You'll need to talk about what are the causes of AF. You'll need to talk about complications, and then further management, admission to the hospital, cardiologist review, just regular blood test. Then you do an echocardiogram of the heart, and the management depends on the stability of the patient. Medical management is the first choice. So control the heart rate. If not, then control the rhythm. It's still not better, then you go for cardioversion. And then don't forget to talk about if the patient needing any anticoagulations. How we measure that? We use a scoring system to find out if you need any anticoagulant or a blood thinner to prevent these complications of a stroke. And we have already measured your risk calculation and it came as 2. According to this scoring system, if it is more than equal to 2, you need a blood thinner so that you can prevent this kind of complications. So what we are going to do is to first make sure your kidney function is fine and stable, and then the cardiologist most likely is going to start you with any of the newer oral anticoagulants, and that you will need to take it for a lifelong. Okay. When you take these blood thinners, there is an increased risk of bleeding from your body. So at any time, if you start to bleed heavily, stop the medication. Sorry, don't ask them to stop the medication. Say that if you start to bleed heavily after taking these medications, please contact with me immediately. And then we will decide the further action. So that will be the part of the whole management. We will discuss this management thing again in our role play sessions. So there is a cardiology role play session coming up in the next class, I think. So in those class, we will also again discuss this one. But this is a basic idea that how the management should be. Any question? Again, don't get too much bothered about this because it usually not the exam cases, but at least you should be always prepared for anything that can come in exam. Okay, now after that, we will start our chest pain plaster. Before we do that, we'll just take a 5-minute break. All right, if you have any question, just ask me after the break. Thank you. All right, everyone, let's start again. Now we are going to start one of the most important cluster in cardiology. That's your chest pain cluster. It's a very important topic. I can't say enough how much it is important because you could see that there's a lot of questions which come from just a couple of cases from chest pain. Chest pain is also important because it gives you an idea about the pain questionnaires. You can use the same pain questionnaires in almost every other pain cases like abdominal pain, headache, any pain. You can use the chest pain questionnaires. So let's start. What are the differential diagnosis of a patient presenting to you with a chest pain? So you are aware that chest pain is not just related to heart. It can come from a lot of other areas. So first of all, we should rule out serious causes. Can be due to angina or AMI, can be pericarditis, aortic dissection or aortic stenosis. All are important cases for exam, especially MI is very important, pericarditis is very important. Lung condition can also come to you with a chest pain, which is pneumonia, pulmonary embolism, very important to rule out, and pneumothorax. GIT related causes, reflux or peptic ulcer disease. Musculoskeletal is also very important, and it's also commonly presented chest pain cause in general practice. So costochondritis is one of the musculoskeletal causes of chest pain. Rib fracture is important to rule out. Some neurological cause like prolapsed disc or herpes zoster. Psychological cause is always an important thing to rule out, like any anxiety or panic attack. So these will be your whole chest pain related causes. A lot of time they will give you patient coming to you with a chest pain, ask history for 6 minutes and give you a diagnosis and did it. So why they give you 6-minute history? Because there is a lot to ask from chest pain. All right, now let's start with our history format. In chest pain cluster, the history format that you need to remember is that the patient having a pain. In exam, anyone who is having pain, you should always offer some painkiller before asking anything. So painkiller is must. You need to make the patient comfortable first before they can give you any history. So that's the basic idea. If you don't give painkiller and you just start talking and talking, you can just fail the exam. So that's one thing. And another one thing is that you need to make sure patient is vitally stable or not. So for a chest pain cluster, let's start with this like, hi John, this is Dr. Arshan. I'm one of the doctor in this emergency department. I understand from the notes that you are having chest pain. I'm very sorry to hear that, but would you please tell me a little bit more about how severe is your chest pain in a scale of 1 to 10? Yes, doctor, I'm having 8 by 10. I'm very sorry to know that. I'm going to offer you some strong painkiller, but do you have any allergy to any medication? No, doctor. Well, that's fine then. I will just arrange painkiller for you. Hopefully you will feel comfortable after that. Now, John, because you are having chest pain and you are in the middle age group, I need to make sure that you are vitally stable. So please excuse me for a moment and I will come back to you. Dear examiner, I would like to know if my patient vitally stable for further history. Now, the tricky point in here is that it depends on the age of the patient. If it's a 30-year-old patient coming to you with a chest pain, you don't need to be too much worried about a heart attack initially. But if it's a 50-year-old coming to you with a sudden onset chest pain, you should be worried about it, right? So in those cases, you should say that, let's say examiner said your patient is vitally stable, please proceed. You should say to the examiner that, dear examiner, as my patient is in the high risk group, especially in terms of his age and the onset of the pain, I would like to transfer my patient to the resuscitation cubicle, call my nurse, and hook my patient to a ECG monitor, start the patient on a 2 large bore IV cannula or insert 2 large bore IV cannula and ask the nurse to take some blood and send it for cardiac enzyme. So all of these things are written in our notes. Just in few minutes time, you will see that. But this is what we normally should do. So anyone like a chest pain, they will be our first priority. So you send the patient to a resuscitation cubicle. In emergency department, usually you will get a resuscitation cubicle always. So they will be transferred to the resuscitation cubicle or resuscitation room, and then you will call for help from the nurse. You can ask the nurse to hook the patient to a ECG monitor for continuous surveillance, and also insert 2 large bore IV cannula, take the blood for necessary investigation, including a cardiac enzyme, which is the troponin. Okay. Once you have done that, then you can start asking questions from the patient. Now, time to time, if in the question already a ECG given, and you can see patient having a myocardial infarction, like ST elevated MI, couple of things should be added in here, which is called monotherapy. That means you give the patient aspirin is the first thing that we start, nitrate, oxygen, and morphine. Okay, so we will come to that point just in a moment time. Is if in the question the stem has a ECG showing that patient having a ST elevated MI, then yes, we will start with a monotherapy from the first. But otherwise, you can wait and you can discuss that in your management. All right. So hopefully I haven't confused you a lot. So make sure in these cases, it depends on a whole lot of things. How is the age of the patient? It's a 30-year-old patient. You just give them painkiller, make sure patient vitally is stable and start asking questions. 50-year-old patient, yes, then you make sure patient is vitally stable, painkiller, but don't forget to take them to the resuscitation cubicle, ECG monitor, and 2 large bore IV cannula, send the blood. Okay, so that's your first thing that you do. After you have done that, then you ask the patient, how are you feeling now? Is that all right if I ask you a few questions, please? Yes, doctor, that's fine. So please tell me a little bit more about your chest pain, John. So patient will give you some information, but you will need to do the Socrates pain questionnaires. The Socrates pain questionnaires include S for site, so where exactly is the pain? O for onset, so when did it start and how did it start? What exactly were you doing when this started? C for character, how does the pain feel like? It's a very important thing that if a patient have burning chest pain, that suggests maybe it's a reflux or peptic ulcer disease. If a patient says that I'm having a sharp stabbing pain, that might be pericarditis. If a patient says that I'm having like a heavy feeling, it feels like someone is squeezing my chest or it feels constricting, then you think about possibility of myocardial infarction. R for radiation. You'd never ask the patient, where do your pain radiate? Patient does not understand radiate. Say that, does the pain go to anywhere? Associated symptom, nausea, vomiting, we will ask it. Time or duration, how long you are having the pain. Very important for MI patient. E for exaggerating, relieving factor. So anything makes it better, anything makes it worse. And S for severity, which we ask initially anyway. So those are all the pain questions that you will have to ask here. So if we go through the pain question, when did it start? What exactly were you doing at that time? Did it start suddenly or gradually? Is it for the first time? Is the pain continuous or on and off? Can you exactly point out where is the site of the pain? Does the pain travel anywhere? Can you describe how the pain feels like? Anything makes it better, anything makes it worse. You can ask directly, anything makes it worse, like taking a deep breath, coughing, or doing any exertion. If the pain get worse with exertion, suggest myocardial infarction or angina. If pain get worse with breathing, coughing, that suggests pericarditis. Okay. So that's your all the chest pain question. So along with the chest pain, have you got any difficulty breathing, any racing of the heart, any nausea, vomiting, or excessive sweating? So that's the questions we are going to ask for AMI. After that, we will go to the differential diagnosis one by one. For pericarditis, does the pain get worse when you lie down? Does it get relief when you lean forward? Any recent flu-like illness? So pericarditis pain will get better when they lean forward. Sometimes in exam, the role player will try to show you that they're having pericarditis just by leaning forward. Okay, so you should be very careful. Sometimes everything that they are doing, there is a purpose for that. For aortic stenosis, any dizziness or sudden blackout? Because we already know that we asked the triad for aortic stenosis, which is chest pain, difficulty breathing, and dizziness. We already asked chest pain and shortness of breath. So just ask the other one, which is dizziness or sudden blackout. Then we move to the lung causes. For pneumonia, any fever, cough, difficulty breathing. For pneumothorax, any trauma to your chest. Not much of things to be asked because pneumothorax also patient with chest pain, difficulty breathing, which we already asked anyway. For pulmonary embolism, any recent long travel to anywhere, any previous or family history of clot in your legs or lungs. So long flight is a very important history to consider DVT causing pulmonary embolism. And previous history of DVT or P with a family history of clotting disorder, also very important. For reflux, does the pain has any relationship with food, any heartburn or any bitter taste in your mouth? For costochondritis, is the chest sore to touch? Patient with costochondritis, they will say that if I press a specific area on the chest, it is very tender to touch. So that's what you think about costochondritis. For herpes zoster, any rash on the chest. Patient with herpes zoster, initially they will have a pain followed by onset of the rash. So sometimes herpes zoster patient also can present to you with a chest pain, but you will never think about it because patient does not have any rash at the moment. So that's also confusing sometimes. And lastly, finish with anxiety or panic question. So give some confidentiality, ask that, are you generally an anxious person? Do you worry a lot about most of the trivial things? Ask about any stress at home or work. Do you smoke, drink alcohol or recreational drugs? Past medical history of diabetes, high blood pressure, cholesterol or heart condition. Family history of heart disease is very important. And are you on any medication? So that's how you ask the chest pain history. As you can see, there is a lot to ask. It always depends how many tasks have you got, and you can always cut it out. Okay, so according to the task, you should be able to cut some of the questions, maybe just rule out the important ones, and then forget about a lot of differential diagnosis. Physical examination is same like before, so nothing is different from what we have done so far. Now moving on to pericarditis. Before we move on, do you guys have any questions on chest pain history? Now, Dr. Priya, the nitrate is usually like you don't need to give nitrate to everyone in chest pain. Only contraindication for giving a nitrate is that if a patient is severely hypotensive or patient having an inferior MI. In those cases, we normally will withhold the nitrate, but other cases you can give. Okay, moving on to pericarditis. Now look at here, 50-year-old patient coming to you with a sudden onset chest pain for 2 hours. If you look at this question, your first thought should not be pericarditis. Your first thought should be acute myocardial infarction, unless you can prove it otherwise, right? So always remember in the exam, the important thing is that you don't know what this patient has got. So treat this patient as a MI unless you get something else. Okay. Positive point in the history you will get is that patient started to have a chest pain since 2 hours, aggravated by lying down or deep breathing, so which is also common. So patient with pericarditis, the chest pain will be stabbing type of pain. It gets worse with leaning down and taking a deep breathing or coughing, better with leaning forward. You might be able to get a recent flu-like illness. That's a very important finding because most of the time that viral illness has also inflamed or infected the pericardium. Sometimes it can radiate to the back and in between the shoulder blade and no other symptoms. So that will be your positive point. In the investigation from examiner, they will give you this ECG. The ECG of pericarditis can be quite confusing, but you will need to have a good basic idea about the ECG not to get confused in the exam, because 50-year-old ECG of pericarditis also shows ST elevation. So you can get confused quite easily. Let's say, what will you do? Remember one thing, that if you get a patient with chest pain, you will look at the chest lead first. So V1 to V6 will be your first inspection. And then you will look at the limb lead. The limb lead that is important is lead 1, lead 2, 3, AVL and AVF. AVR not important to look at. There are mainly two MI that you will be looking for, anterior MI or inferior MI. The anterior leads are V1 to V6. The inferior leads are lead 2, lead 3, and lead AVL. So what is this what is this 1 and AVL? Lead 1 and lead AVL is the lateral leads. Okay, so V1 to V6 anterior lead, lead 1 and AVL is lateral lead, lead 2, 3 and AVF is the inferior lead. So now that you know the name of the leads, next thing you look at is if there any kind of ST elevation in those leads. First look at the V1, it looks fine. So you have got P wave, QRS complex, ST wave. Now after that, you will be looking at V2. In V2, what you have got, this is P wave, then there is a QRS complex. When you see here, this is called isoelectric line. Okay, so ST elevation means the ST wave will be displaced upward from this isoelectric line. So obviously this ST wave has been elevated. So that's ST elevation. If you look at lead 3, it's quite easy to get it. So isoelectric line is here, but see where is the ST elevation, right? So that's ST elevation. Lead V4 ST elevation, V5, V6 ST elevation. So widespread ST elevation. in V2, V3, V4, V5, V6. When you get a ST elevation in these leads, you should immediately look at lead 1 and AVL. In lead 1, ST elevation, lead AVL, there is ST elevation a little bit. So you have got ST elevation in all the anterior and lateral leads. Now, will you stop there? Just think that it's a ST elevated MI or anterolateral MI? No. Look at lead 2, 3 AVL. Lead 2 also has got a ST elevation. Lead 3, nothing. Lead AVF has got a little bit, not too much. Okay? But lead 2 has got a ST elevation. Now, the important thing to remember, so keep your head straight in this statement, is that in a patient with a myocardial infarction, the rule is if you have got ST elevation in the anterior leads, you should get a reciprocal ST depression in the inferior lead and vice versa. So what I said, if this patient has got ST elevation in V4, V5, V6, that means all the anterior leads has got ST elevation. As a rule, patient should get a reciprocal ST depression, not ST elevation. So this patient should have got a ST depression, or even sometimes just a ideal or a isoelectric thing. So the main thing that they should not get a ST elevation in both anterior and inferior lead at the same time. Okay, when you have got a global ST elevation everywhere, anterior lead, lateral lead, inferior lead, that's the time you should be cautious that it might be pericarditis. Okay, and the pericarditis ST elevation is also typical. They get a concavity upwards. Like see the concavity upwards, ST elevation like this. You can see this. It feels like you can sit in on this like a chair. Okay, so that's called concavity upwards ST elevation, which is also very important finding in pericarditis patient. In case of a myocardial infarction, you don't get a concavity upward kind of ST elevation. Is this clear, guys? So when you explain such a ECG to the examiner, you will just use the same formula. So this is the ECG of my patient, blah, 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 who presented with chest pain. The heart rate. Now in here, you can't talk a lot about the heart rate. You can just say heart rate looks normal with regular rhythm. P wave is normal. QRS complex normal, but there is widespread ST elevation in from V2 to V6, lead 1 and AVL and lead 2. Okay, and also I can see the ST elevation is concavity upwards. There is no change in the T wave, like T wave is normal in size and shape and QT interval is normal. So that will be your ECG explanation. So explain to the patient that most likely from history and physical examination and also the electrocardiogram, you are having a condition called acute pericarditis. Do you know what it is? No, doctor. Well, it is a condition where there is inflammation of the outer layer of your heart called pericardium. You can draw a picture also if you want. Most likely it's due to the reaction of the viral infection that you had a week before. As the covering of the heart is inflamed, it's causing this stabbing pain that you are having, and that also get worse when you lie down and get better when you lean forward. It could be due to other reason as well, like it could be heart attack, but your ECG findings are not similar to a heart attack ECG. And also the feature of your chest pain does not go with the heart attack. And then give other differential diagnosis. Please don't worry, most likely it's not a heart attack, but to confirm my diagnosis and to exclude it, I would need to keep you under observation in the hospital. I will call my senior and a heart specialist will come and see you. Just to be sure, we will do some blood test, including full blood count, inflammatory marker, kidney and liver function, and some repeat ECG in 2 to 4 hours time with a repeat troponin, which is a cardiac enzyme, to rule out the possibility of heart attack. And also we will check your heart structural condition, and also to rule out any other possibilities. We will do a special test called echocardiogram, which is just a scan of your heart. If it is confirmed that you don't have a heart attack and it is likely to be a pericarditis, then there is nothing you need to worry about. You just need to take some bed rest and just some simple painkillers, because it's a viral induced pain. It will get better in few days time. Do you have any questions? Okay, so that will be your pericarditis case. Any question, guys? Did you get the ECG of pericarditis? Very important not to get confused. The one other thing that I would like to address, that when you start this case, because it's a 50-year-old patient, you should take that patient to the resuscitation cubicle, do the ECG, take the blood, the whole initial thing, you should do it here as well. Okay, moving on to acute myocardial infarction. A 55-year-old man comes to your ED with a sudden onset crushing chest pain. Now, the question, and you will know that what they're talking about. Task is take history, physical examination from examiner, ask investigation from examiner, and explain the likely cause of his chest pain and immediate management. So that's one of the very important case in exam. Sometimes they will give you ECG in the stem as well. If ECG is given in the stem, your history does not need to be that much detail. Like you don't need to ask all the differential diagnosis of chest pain in that case. Okay, that's usually the case for exam, because if you need to take a whole history of chest pain, you will not be able to finish these 4 or 5 tasks. So they give you the ECG so that you understand that they are talking about MI. And if you know the ECG of MI, what are you going to do? That's the thing. So the positive points in the history is that acute onset of severe chest pain, crushing in nature, which is radiating to the neck, jaw, and left arm, and it is for the first time. So you know that MI patient, it comes as a sudden onset of left-sided chest pain, which can radiate to the left arm, neck, and jaw. Usually, the pain will be crushing in nature, and patient pain will be severe, like 9/10, and you might need to give them morphine. Also, you will see that patient having, there is no burning chest pain. It does not have any relationship with coughing or deep breathing. No features of pericarditis you will get here. Associated shortness of breath, nausea, vomiting, and sweating can be there. The important finding you will be looking for in the history, like your chest pain question will be same, then associated symptom will be same. You will ask a little bit of differential diagnosis, maybe very quickly aortic dissection you will ask, okay? And very quickly you can ask any fever, any chest pain, shortness of breath. You will ask about pulmonary embolism and pneumothorax very quickly if you can. If not, that's fine. But the main thing that you should not forget is the risk factor of heart condition. The risk factor of MI, we will come to that question later on, but important is smoking, alcohol. We need to find out if the patient already have some known condition like high cholesterol, diabetes. We need to find out a family history of heart condition, lack of exercise or sedentary lifestyle, and also if the patient is not taking healthy balanced diet, like someone who is eating all the junk food, fatty food, they are high risk. Okay, so in your history, you will just need to find out SADMA, so smoking, alcohol, recreational drugs. You will also find out any family history of heart condition. You will find out any other past medical condition like diabetes, high blood pressure, or high cholesterol. And very quickly just ask that, do you do any kind of exercise? How is your diet? So that will be your history wrapping up. You don't need to ask too much DD if you already know the diagnosis by the ECG in the stem. But if ECG is not given in the stem, then you will need to ask a little bit more differential diagnosis here. Okay, so you always change your pattern based on what is given in the stem. So that's your positive points. In this case, as we discussed that this is a high risk case, you will need to take this patient to the resuscitation cubicle, attach him on cardiac monitor, ask the nurse to do an ECG, secure 2 large bore IV cannula, take the blood for full blood examination, cardiac enzymes, including a troponin. If the oxygen saturation less than 95, start the patient on oxygen. Okay, so that will be your initial management. If you know from the stem patient having a myocardial infarction, like the ECG showing ST elevated MI, you can also say here that you would like to start the patient with a 300 milligrams aspirin. Morphine you already started as a painkiller. Oxygen you already talked about. And nitrate, if even after giving the morphine, patient is having chest pain and no other contraindication, you can also give nitrate. Okay, so you can talk it here initially, or you can talk it in the immediate management part. Any of this is fine, as long as you are talking about it. Okay, now look at this ECG and tell me what you have found, guys. Or let's look at another one, maybe this one. Yeah, look at this one. Yeah, that was the inferior MI, Dr. Bhavin, good. Now, if we look at here, you can see that first we look at V1. V1 is fine. Look at the V2. This is the isoelectric line and the ST wave is already elevated. This point that you see here, that's called J point. And the J point is always elevated in the ST elevated MI. Lead V3, you can see V4 elevated, V5 elevated, V6 elevated. So V2 to V6 elevated. Lead 1 and AVL is the next thing. So lead 1 and AVL also elevated. So you can say that it's an extensive MI, or you can say that it's an anterolateral MI. Lead 2, 3 AVF. Lead 2 is fine. Lead 3, okay. Lead AVF is also normal. Now that's how you will get in the exam or in the myocardial infarction. The inferior lead should be normal or depressed. So that's your ST elevated MI or anterolateral MI. Okay. How about this one? It's same. So if you look at here, V1 elevated, V2 elevated, V3 elevated, V4 elevated, V5, V6 not too much, lead 1 elevated, lead AVL elevated. So that's again an anterolateral MI. But if you look at lead 2, 3 AVF, those are fine. Now the management. Now explanation of ECG will be same. So you will just need to explain that there is ST elevation in this leads. So in the management or explanation, you will say that, thank you, John, for waiting. Now, John, based on the nature of your chest pain and according to the electrocardiogram, most likely, I'm suspecting that you are having a condition called acute myocardial infarction or heart attack. John, I'm really sorry, but it is a serious condition. In this condition, the blood pipe that supplies your heart get blocked by some clot. And as a result of that, your heart is not getting enough blood and oxygen. And that can lead to serious complication if we can't treat you urgently. But please don't get scared because you are here within 30 minutes and you are in safe hands. I really appreciate that you have come early, and with proper intervention, we can manage it very effectively without any serious complication. but I need to admit you urgently in the hospital, I will call the cardiologist and my senior who will come and review you for further management. In the meantime, I'm going to give you a tablet called aspirin, which is the kind of a blood thinner you need to chew only. This will help us to prevent any further formation of clot. I have already given you a stronger painkiller and will continue until you feel comfortable. If you have ongoing chest pain, even after morphine, we can also give you another medication called nitroglycerin spray. If your oxygen coming down, then we will also start you with an oxygen by mask. This is the usual immediate management for someone who has heart attack. The specialist will come and see you immediately. He might want to do further investigation. We'll do some basic blood tests. So talk about all the basic bloods, including the troponin. The definitive treatment of this condition is to improve the clot, is to remove the clot and restore the blood flow, what we call PCI, which is percutaneous coronary intervention or thrombolysis. This will be decided by the specialist based on the duration and severity of your condition. Okay, now the thing is that they just asked you to talk about the immediate management. Your immediate management finish here. As long as you talk about the initial monotherapy, you're talking about the basic blood test. Don't forget about the troponin, that must. Now, it's not even must in here because you already have got ST elevated MI. Troponin is not must, but just talk about all these blood tests and say that the definitive treatment of this condition is to remove the clot and the restore of the blood flow, which can be done either by stenting or by thrombolysis, which is a medication which can dissolve the clot. This will be decided by the specialist based on the duration and severity of your condition, and it will be discussed in detail what is the best option for you. Now, in here you can see that we have written about once you discharged, we will start you on medication, healthy lifestyle. Now, this part is not needed at the moment. What you should do is that just say that this is the immediate management, reassure the patient and say that, John, I understand that it must be very overwhelming for you and you must be very worried. But I would like you to know that we have a very good team of cardiologists in this hospital and they are going to take care of you. You will be in a constant supervision until we are treating you and until the blood flow is completely restored. I want you to know that there are millions of people who is suffering from this condition, and we get a lot of patients exactly like yours, and sometimes they can even just go to their home within 1 or 2 days. So just make sure that if you are feeling really uncomfortable, let us know so that we can manage your symptoms. If you want us to call your friends or family members, I will be happy to do that. If you have any questions at any time, don't hesitate to ask me multiple times. Okay, so finish in this way. You don't need to talk about what's going to happen after discharge or during discharge because it's a little bit early to talk about it. Okay, so that's your immediate management, and this part is actually the long-term management. Sometimes they ask you like initial and long-term management, then we talk about this, but for this case we don't need to do that. And you might be thinking that do we need to discuss about stenting or thrombolysis? Not always. If you have some time, you can just say that what is percutaneous coronary intervention, so and also what is thrombolysis. So in a very simple word, you can just say that, well, in percutaneous coronary intervention, which is the ideal management for your condition, we need a catheter lab. In the catheter lab, they will put you in sleep, and then we will insert a tiny flexible tube or a wire from your arm or from your groin, and that wire will go into your heart arteries, and then we will exactly locate where is your block. Then the specialist will put on a device known as a stent, which will widen the arteries, and then the blood flow will be restored. Okay, and the thrombolysis is usually the second line medication management. If we don't have time for catheter lab or the ideal time has been gone, then the specialist might go for this thrombolytic medication. In those cases, they will ask you a range of questions to ensure you don't have any contraindication to this medication. And if they're happy to do that, then they will give you this medication, and that can dissolve any clot that your heart has formed. Okay, usually thrombolysis is the choice for a rural area, not in the tertiary area. Any question, guys? So there is a question that very commonly come in exam is, you are in a rural hospital or you are in a rural GP center, and the next tertiary hospital is 4 hours away. You have got a patient who is having a sudden onset of chest pain 30 minutes back. They have given you a ECG showing ST elevated MI, and they're asking you, take a short focused history, physical examination, investigation from examiner, explain the diagnosis with the immediate management. So rural hospital, which is 4 hours away, the golden thing is that any patient who come to you with a myocardial infarction like this, especially if it is a ST elevated MI, the patient should be sent to the catheter lab within 90 minutes. If you can't do that, if 90 minutes you don't, like this patient needs to be transferred 4 hours distant. So the 90-minute goal is lost here. In those situations, the ideal thing is to not to send the patient to the tertiary hospital immediately. Rather, you liaise with the cardiologist in the tertiary hospital and start the patient with thrombolytic medication. And then once patient is stable, you can transfer the patient to the tertiary hospital. Okay. So that will be the management for that case. So you will need to make sure that you say that this is because we are in a rural hospital and the nearest tertiary hospital is 4 hours away. And the golden time to send you to a catheter lab to put a stent is a further than what is intended. So what we are going to do is to liaise with the cardiologist in the tertiary hospital, and then likely that we are going to start you with a medication called thrombolytic agent to dissolve the clot. Okay, so that will be the management for that particular case, but the monotherapy, all other things are same, just the management is different. If you are considering thrombolytic medication, you need to rule out the contraindication of those medication. Especially in your history, you will need to ask that, have you had any kind of head injury or any stroke recently? Any hemorrhagic stroke, especially in the last 12 months? If the patient having any other blood thinner, if a patient having bleeding disorders, you can't start them with this medication. Okay, so especially at least if you can ask these questions, so head injury, any ischemic stroke or hemorrhagic stroke in the last 12 months, ask about patient already on any anticoagulants or blood thinner or not, or if they are having any blood related disorder or clotting disorders. And then you can start the patient with this medication. Okay, all good? Any question with this chest pain? Did you guys get an idea that how you are going to start this case? Because that's the area where people get really confused. So it's very easy now. So what you will need to do when you start the history, make sure you introduce yourself, reassure the patient, offer painkiller, and ask the hemodynamic stability from the examiner. Even if the examiner says that patient is stable, you should say to the examiner that you are going to do these days. And if you have already got immediate management in the task, and you know that it's the ST elevated MI, you can talk about monotherapy initially or during the immediate management. It's your choice. There is no problem with that. Okay, but as long as you are doing that, you are fine. That's all good. We will do the role play of these cases anyway in our next session. So if you have any problem, you can always get some idea, because with role play, we find out that where exactly you are doing wrong. So that's not a problem. So next question is angina. You are in a GP setting, a 62-year-old male who presented a few days ago with chest discomfort. ECG done at that time was normal. A stress test was done later on, showing ST segment change in the anterolateral leads. Patient has chest tightness during the test. Now that's what we call as angina. That means patient had a chest pain, resting ECG was normal. Then you send the patient for a stress test and you found patient was having chest pain during the test and also some ST changes. Patient is a known smoker, no history of diabetes. Explain the test result and talk about short and long-term management. This is basically just talking about angina, which is not very hard for the exam. So say that, hi, Mr. John, this is Dr. Arshan. I'm one of the GP in this clinic. It's very nice to meet you. I understand that you recently had a chest pain and we did a ECG and that was normal. And then you were sent for a stress test. Is that right? Yes, doctor. So tell me, how did the stress test go? Then a patient will say, yes, doctor, I was having some chest tightness, so they had to stop. Oh, I'm very sorry to hear that. But please don't worry, because now that you are here, we are going to ensure that your symptoms are well managed. So, John, first of all, let me discuss that what we have done in our test. So in the stress test, when you were running on a treadmill, you had a chest tightness. And also we checked your ECG during that time, which shows some changes, and that lead me to think about a possible condition known as angina, or in a simple word, it's a heart pain. Do you understand what I am talking about? No, doctor, what is angina? Well, angina is the name given to the chest pain or discomfort that comes from your heart when it is short of oxygen. Let me draw a picture for your better understanding. So this is your heart, and your heart has some blood pipes known as coronary arteries, which is supposed to supply your blood. But in this condition, these blood pipes get narrowed due to deposition of some fatty substances. And as a result of that, when you do some exercise, your heart cannot get enough oxygen. And that's the time you experience chest tightness or pain. Are you with me so far? Always when your task is just counseling, which means 8 minutes you will just need to talk, every now and then, just say, are you with me so far? Are you understanding me? So that patient does not sleep when you are talking. So, yes, doctor, I'm fine. Now, please don't get scared about it. It's a very common condition. Millions of people are suffering from it. But unfortunately, it can lead to serious complications known as heart attack. That's why it is very important to follow a healthy lifestyle to prevent any further progression of this condition. Regarding management, first of all, now, even before management, what I would like you to do is that do some basic blood test on this patient. I think this is not written in here, but before any management, just start the patient with some basic investigations if you haven't done it yet. So first of all, I'm going to make sure that we do have some basic baseline blood tests in our hand. So we'll do some full blood count, your liver and kidney functions. We will check your lipid or cholesterol level. We'll check for your blood sugar. We'll check for any thyroid function abnormalities. And then we will also, now if you do just that, that's fine. Okay, so mainly for heart related thing, as long as you are having some idea about their cholesterol level and their blood sugar level, that's the main thing that you should rule out. Okay, so do some baseline blood test. You can also do a ECG, baseline ECG if you want, but that's also has been done already, so no need to do it now. So just order some basic blood test and then talk about further management. So regarding management, I will start you on some medication known as aspirin, beta blocker, statin, and triglyceride, or you can, or GTN, which is the glycerol trinitrate. Now discuss a little bit about those medication. So you can say that aspirin is a kind of a blood thinner which will help to prevent further progression of this clot. Beta blocker is a medication which is actually supposed to lower down your heart rate, but in terms of angina, it also helps to prevent any remodeling of your heart, and it gives stability to your heart. Statin to lower down the cholesterol level, but we will see how is your cholesterol level initially by those blood tests. I will give you a GTN spray, which is a nitroglycerin spray, which you should carry with you all the time in case you have chest pain. Also, try to adopt a healthy lifestyle. So cut down your alcohol to the safe level. Please try to maintain an ideal body weight. Please avoid smoking. Take healthy balanced diet. Do some exercise, ideally 30 minutes of brisk walking most of the days of the week. And try to avoid stressful work as well. Once we have done this fund management, I will also refer you to a cardiologist for further assessment. Most likely, the cardiologist will go for an angiogram. In coronary angiogram, they will put a dye into your heart arteries to see how much blockage you have got in your arteries. And based on the result, they will decide if you need any further management. If you have more than 70% block in multiple arteries, even sometimes 90 or 100%, most likely the specialist might want to put a stent inside those arteries to keep it open. But if it is a very severe kind of blockage, they can also talk about open heart surgery. Please don't get scared about any of this right now, because all of this will be discussed in detail by your specialist and will be decided based on your result. If your angiogram report is not that bad, you don't need anything apart from just lifestyle modification and this medication that I talked about. If you again have this sort of chest pain, please follow the angina action plan that I am talking about. So in terms of a severe or prolonged pain, even after taking a rest, especially if you have taken rest, still chest pain persists for more than 10 minutes, take this nitroglycerin spray under your tongue. Wait for 5 minutes. If it is not relieved, then notify a friend or relative that you are having the chest pain. If after 5 minutes still pain persists, repeat the dose and wait for another 5 minutes. If it is not relieved, call ambulance, take the third dose, and tell the ambulance that you are having a heart attack. Okay? Give reading materials and reassure the patient and say that you are going to review the patient regularly. Okay? So the angina action plan is the main thing in this case. You have to talk about it. So patient having a prolonged chest pain, then they take 1 dose glycerin spray, wait for 5 minutes. Still pain there, another dose, wait for 5 minutes. Second time you have given the spray and you waited 5 times, still having the pain, call ambulance, say that you are having a heart attack, and then give a third dose. Patient can give 3 doses of this nitroglycerin spray at a time, maximum. Okay, so that angina action plan you will have to discuss in this case. Not very hard case, it's very easy. Any question? Good. Next case is angina due to anemia. A 50-year-old man is in your GP clinic complaining of chest pain and dizziness for the last 1 month. Now, 1 month chest pain, you should not be very much cautious about heart attack. You will be ruling that out, but 1 month chest pain, unlikely to be a acute MI, right? So history, physical examination from examiner, diagnosis and further management is your task. So in this case, again, the history is same. So you will ask about chest pain, ask a little bit about dizziness, and then ask all the CVS CNA, all the CVS lung, all the differential diagnosis questions that we have known. So you will find out patient having on and off chest pain, which is 5 to 6 by 10, so mild to moderate, constricting, retrosternal, comes and goes, precipitated by effort, relieved by rest, and sometimes radiate. Now, that means that this is the angina pain, right? Dizziness, patient feel tired and weak, especially when they stand from sitting or lying position. That means that they might have some postural hypotension also. Smoker for the last 15 years, drink alcohol for 10 years, cholesterol normal, diet healthy, no other medication, no history of heart attack. Physical examination, patient looks pale. Now, that's what is important in this case. So that's what we call as angina due to anemia. If a patient losing blood from somewhere constantly, and patient does not know, which is occult loss of blood. In those cases, patient can develop anemia, and that anemia can give angina-like pain. You have also seen that blood pressure sitting is 120 by 80, but when he stand, it's about 105 by 80. Normally, you will get more than 20 drop in case of postural hypotension, but still you can see there is some drop here. Pulse rate 90, regular, other examinations fine. You have got blood on your finger on DRE. Blood in their stool. So you will do the same thing. So neck, CVS. After CVS, you should do respiratory system and abdomen. In the abdomen, you will do you'll just do a very fast inspection, palpation, auscultation, and then you will talk about the DRE. Now, there is a lot of things to be learned in the abdominal physical exam, which I don't want to go today, okay? But just make sure, don't forget about doing a DRE in this case, because in the DRE, you will get blood. And that's the time you think about patient losing blood in their stool. So history in this case, so you will start with the chest pain question, offer some painkiller, but you don't need to make sure patient is vitally stable or not. Dizziness question, so tell me more about what you mean by dizziness, any loss of consciousness, any relationship with change of posture or position. Ask the associated symptom and all the differential questions like before. In this case, when you come for dizziness or when you come for anemia causing chest pain, just add anemia question here. So especially for chest pain for a prolonged duration of time, anemia also will be your one of the differential. So when you ask the anemia question, you will ask, do you feel tired and weak these days? Patient will say yes. That's the time you should get a prompt in your head that, is this patient getting any anemia related angina? Then you ask the detailed question about anemia. So do you take healthy balanced diet to rule out iron deficiency anemia? Any loss of weight, loss of appetite? Any change in your bowel motion? Have you noticed any change in the color of the stool or urine? Or have you noticed any blood in your stool or urine? Any history of heartburn or indigestion? Any pain in your tummy? Why we are asking all these questions? To find out if the patient losing any blood. The iron deficiency anemia is usually the cause. So diet to rule out dietary deficiency. The second is any bleeding. So bleeding can be from anywhere. You can directly ask them, are you bleeding excessively from anywhere? Also directly ask that, have you noticed any blood in your stool or any change in your bowel habit? Ask about loss of weight, loss of appetite to rule out possibility of cancer. And to rule out peptic ulcer disease causing this bleeding, ask any heartburn, any indigestion or any abdominal pain. Okay. Lastly, just past medical history. Don't forget to ask about past medical history of any peptic ulcer disease. Family history and SADMA. In the SADMA, what is important? Anyone? Smoking alcohol is important, but if I ask you one medication which will be important to ask here, what will you do? Yes, very good, Dr. Sobia. NSAIDs. So patient might be taking anti-inflammatories for their back pain for a long time, and that might be the cause of bleeding. In the physical examination, as we know that we will do the same thing, general appearance. In the pickled, don't forget about pallor, vitals, BMI, CVS, abdomen, don't forget to do DRE. In the management, so from history and physical examination, most likely you are having a condition called angina due to anemia. Do you know what it is? No, doctor. Well, anemia means lack of blood in your body, which is most likely due to loss of blood from your back passes. And due to lack of blood supply, your heart is not getting enough blood and oxygen, and that's the reason of your chest pain and discomfort. And that is what we call as angina. So you'll just need to explain both. What is anemia? Lack of blood. And how it happened? Because when I checked your back passes, I have found some blood in my finger. Most likely you're losing some blood with your stool. And because of the lack of blood supply, your heart is not getting enough blood. And that's causing the chest pain or discomfort known as angina. Please don't get scared about it. It's good that you are here. Now we can manage your symptoms accordingly. Right now, I will admit you to the hospital because you might need some fluids. Now, it's not very important to start the patient with fluid unless patient is dehydrated. There is a little bit of drop of blood pressure, but that's not the reason of starting the fluid. So it depends. If patient looks very tired, fatigued, and dehydrated, you can start the patient with fluid. Otherwise, no need. So right now, I need to admit you to the hospital. You will be seen by my senior, and also we will involve the bowel specialist and the heart specialist for further investigation and management. The further investigations that will be done are some blood tests and some other special tests. Blood test will include full blood exam to see that how much blood you are lacking of, inflammatory marker, a ECG to rule out any other possibility of chest pain, iron studies to see that if you are having iron deficiency anemia, blood grouping and cross matching, liver function, kidney function, blood sugar, and a cardiac enzyme. Specialists might also want to do two other special tests known as endoscopy and colonoscopy. In this test, you will be in a sleep and a flexible tube will be passed from your mouth into your stomach and from your back passes into your gut to look for any suspicious lesions there. And they might take a sample from those lesions if they think that those are suspicious. It is very important to do that because we have found some blood in your stool. And you are also getting chest pain and you're getting complications from those. And your age also puts you in a risk of such cancer. So it's important that we do those two investigations to rule out any possibility of any nasty lesions in your stomach or in your gut. Once we know about all these blood tests, further management will be done accordingly by your specialist. Okay, so that's how you are going to talk about this case. And lastly, finish with 4R. Any question? Now, this angina is not a super important cases in the exam. It's more important is the one that we have done like pericarditis, the myocardial infarction, those are more important. But it's just something which you should know about. No, there is no need of doing the FOBT because you have already got stool on your finger. The stool examination or FOBT is mainly for occult blood. When you already have got the blood, there is no need for doing the FOBT anymore. The 4R, Dr. Sobia, is, okay, so you guys did not do our last class. So 4R means, first of all, 4R is refer, review, reading materials, red flags. So that's how we finish our management. So if you need to refer a patient to the hospital, to the specialist, that's what you talk about. Like in this case, you are admitting the patient in the hospital and you are involving gastroenterologist and cardiologist. So you referred. Review, you're in the hospital, so there is no need of review in here. So you can say that once all these investigations are done, again, you will be reviewed by us or you will be reviewed by your GP. So review is not very important when you are admitting a patient to the hospital, because review comes when you are discharging a patient. So don't talk about review in this case. And review is mainly important in the GP setting because you are reviewing the patient in GP setting most of the time. Reading materials, just give some reading material about the case that you have talked about so that patient has some idea. Red flag is very important. Like if red flag means what a patient should know about the condition and when a patient should come urgently to see you. Like for this case, if you are getting a chest pain that persists, that is very severe, and it goes to your arm, neck, and jaw, and also if you are getting difficulty breathing, if you feel generally very unwell, please come to me immediately or call ambulance. So based on your condition, just keep the most important symptom which patient should be aware of. That's red flags. Yes, Dr. Farshid, for this case, you can just send the patient to the hospital because patient does not have any pain right now. You don't need ambulance for that. Now, for such a case, if you're in the GP setting, it's not even urgent to send the patient to the hospital. So what you can do is that if you're in the GP setting, you will organize the blood test and you will make a referral to the gastroenterologist so that they can just do the endoscopy and colonoscopy as an outpatient. And once this is done, then it will be treated accordingly by them anyway. But in exam, if you are not sure, if you think that it's not just anemia causing the angina, and if a patient is looking unwell, like for this patient who is feeling very dizzy, lightheadedness, you can send them to the hospital just as a precaution. If you are not sure, if you think that something else is going on, it's never ever a bad idea to send the patient to the hospital so that they can stay there for a few days and have all tests done at the same time. All good? Now, the last case for tonight is the CVS risk assessment. CVS risk assessment, it's a important case which come in exam, so have an idea about it. So you are a GP, a middle-aged man come to have a consultation after his brother went for coronary bypass 2 weeks ago. He is obese, no other past medical history. Focused history from the patient, physical examination finding from examiner, and explain what will be the initial management. So this is what we call as CVS risk assessment. So this patient coming to you because his brother had a coronary bypass 2 weeks ago. When you take a CVS risk assessment, we follow the mnemonic called ABCDEFS. It's not a very hard history. So what you should do in these cases, always remember when you get to know from this term that someone is sick in their family, always make sure initially talk about it. Like, hi John, this is Dr. Arshan. I'm one of the GP in this clinic. It's very nice to meet you. I understand from the notes that your brother had a coronary bypass 2 weeks ago. Is that right? Yes, doctor. Oh, I'm very sorry to hear that. How is your brother doing right now? Yes, doctor, he's doing fine now after bypass. Well, that's good to know. Now, I understand that you might be worried about it. So would you please tell me a little bit more about what's bringing you here today? Then patient will say that, doctor, I'm very worried about it because I don't want to end up like my brother. So I want to know what I can do to prevent it. appreciate the patient for this. Say that, oh, say that it's very appreciating that you are here to discuss about it. I'm very happy to know that. So I'm going to ask you questions to find out your risk of having a heart condition in the next 5 years. And then we will manage you accordingly. So then you will need to ask questions according to this ABCDEFS. So what is this ABCDEFS? A for alcohol, B for blood pressure and body weight, C for cholesterol, D for diet and diabetes, E for exercise, F for family history of diabetes, high blood pressure and heart disease. One S for smoking, another S for stress. So that's ABCDEFS. Okay. Now, you can't ask about alcohol and smoking in your first question. So first question you can ask that, just ask about some symptomatic question from the patient. So tell me, how are you feeling these days? Have you got any chest pain, any difficulty breathing, any racing of your heart? Okay, so that's your initial question. Then you can ask that, how's your diet? Do you take a healthy balanced diet? Okay, how about exercise? Do you know about your body weight? Do you have any medical condition, especially any high blood pressure or high cholesterol? Any history of diabetes? Any family history of diabetes or any heart condition? Do you smoke? How about drinking alcohol? Any other past medical or surgical condition? Any medication you are taking? See that if you just ask in this way, everything will be covered. Okay, so not too much questions in here, just your history should focus on the risk assessment. Then your physical examination. So in physical examination, try to find out any risk of having a heart condition. So do the general appearance. So dear examiner, I would like to do physical examination on my patient. First, on general appearance, does my patient looks comfortable or in distress? Any sign of high cholesterol like any xanthelasma or xanthoma, any corneal arcus, any pallor icterus, lymphadenopathy, any dehydration or a sign of edema. I would like to know about the vital. What is very important in the vitals? Blood pressure and BMI. Cardiovascular inspection, palpation, auscultation. Respiratory. Is there bilateral equal air entry? Any other added sound? Do the abdomen quickly. So in this case, especially for CVS risk assessment, abdomen is not very important. So you can just say that after CVS and respiratory, you can say you would like to do whole other systemic examination, especially an abdominal exam and neurological exam. Office test, urine dipstick, blood sugar, and a ECG. Okay. So why urine dipstick? Especially to rule out if the patient having any glucose in their urine or any ketone. BSL for high blood sugar and ECG is a part of your risk assessment. Now, at the end of your physical examination, ask the examiner that, dear examiner, I would like to use a 5-yearly cardiovascular risk assessment chart. Now, you can ask for it to the examiner. Examiner might or might not give it to you. If they give it to you, then you'll need to use that chart to say what is the percentage of risk this patient having. We'll discuss about it in a moment. But let's say patient examiner did not give you that CVS risk assessment chart. What will you do? So your physical examination is done. You will explain that, well, thank you so much for waiting, John. From history and examination, I have found some of the risk factors, like you have high blood pressure, your body weight is higher than normal, you have diabetes, and also your diet contains fatty food rather than healthy balanced food. And you have been smoking for 20 years. So it depends that what you get in the finding. All this can put you on some risk of having heart-related complication in the future. But please don't get scared. We can prevent this by adopting a healthy lifestyle. So I would advise you to cut down your alcohol to safe level, which is 2 standard drink in a day. Try to maintain an ideal body weight. Avoid smoking. Please try to take a healthy, balanced diet and do some exercise, ideally 30 minutes. Try to avoid stressful work. If you think that you need further help, I can also refer you to a dietitian and an exercise physiologist who can help you to show you what is the ideal level of exercise that you should do, and the dietitian can go through with your diet. So you can send this patient to them. Also, I would like to arrange some investigations like full blood examination, liver and kidney functions, a baseline electrocardiogram of your heart, blood sugar level, and a lipid profile. And lastly, say that you are going to review the patient once these results are back. No need of referral. You will give some reading material about everything that you have discussed, and say that at any time if you get chest pain which is left-sided, which goes to your left arm, neck, and jaw, please call an ambulance and or come back to me immediately. That's your red flag. Okay, so that's this serious risk assessment case. Now, I was talking about another case. If you have got this risk assessment chart from the examiner, then you will need to use this chart and put the patient finding in here. In that case, you will know some more finding from your history or physical exam. You will find out that what is the cholesterol level for the patient, because you will need cholesterol level for this chart, and obviously you will get the blood pressure. So only thing that you need to fill this chart is that what is the age of the patient, sex of the patient, is it a smoker or non-smoker, diabetic or without diabetes, systolic blood pressure, and cholesterol HDL ratio. Okay, now let's say our patient is a 57-year-old male. He is a smoker. Systolic blood pressure is 160 and cholesterol HDL ratio is 8:1. So first of all, our patient is 57-year-old male who is a smoker. So male, smoker, 57. So this group. So we are mainly looking into this side, right? So this box is the box that we are looking at. Now, get an idea first. In the serious risk assessment, if you look at this right lower box, you can see 120, 140, 160, right? So this box, the highest number that you can put in here is 130, not 120. This box up to 150, this box up to 170, and like this. So you just add 10. Okay, so that's where people get confused. Which means that if a patient's systolic blood pressure is 125, where will you put this patient? In this box or this box? This box, because up to 130 you can put it here. Okay, so don't get confused. The next one is cholesterol HDL ratio. You can see 4, 5, 6, 7, and 8 here. But this box, the highest number that you can put in is up to 4.5. Same in here, up to 5.5, 6.5, 7.5, okay, like this. Another important thing to remember is that if it's marginal, like you have got 130, I say that up to 130 you can put it in this box, but when it's marginal, always go to the next box. That means put 130 in this box. That's usually the thing, is that if it's a marginal, we go to the next box. Okay, same with this one as well. If it's 4.5, we will choose this box. Is this understandable for everyone? Do you need me to repeat it? Okay, all right. Now let's say that where our patient will So we know that our patient's systolic blood pressure is 160. So where the 160 is, so this is 160. So this will be the box where our patient might be in. The cholesterol HDL ratio is 8. So 8 means here. So if we go up, so this red box is the box that we are looking for our patient. Now you compare this red to this boxes. So you can see that red box means is the highest risk, more than 30%. Okay. So then you will just need to use this chart and show to the patient, see that we have put your age, your sex, your smoking, your blood pressure and cholesterol in this chart. And it shows that you are in the highest risk of having a heart related complication in the next 5 years. Okay. So to repeat this one, you will need all these things like is it a man or woman, smoker or non-smoker, age of the patient, systolic blood pressure and cholesterol HDL ratio. You have got the age of our patient is 57, so it will fall here. Then you have got is a man and a smoker. So we are looking for this box. Then you will look for where our patient's blood pressure falls. 160 means in this box, right? And 8 is the cholesterol HDL ratio. So we'll use this one. So if we go up, so red is our box in here. So it's just like a graph. And the other thing that we have discussed is the highest point. So it shows in here it's 120 is the systolic blood pressure. But this box means the whole of these boxes, the highest number you can put in this box are up to 130. This one 150, this one 170, like this. In cholesterol HDL ratio, it shows 4 in here, but the highest number that you can put it here is 4.5. Here 5.5, 6.5, 7.5, 8.5. Okay, clear? Dr. Michela? Okay, so that brings us to the finishing of our tonight's session. I hope that you guys enjoyed the cardiology session and have some idea about it. Any question from our tonight's session? Any question about the course? So Dr. Sidra asked if it is what, 167? So if it's 167, you can see that up to 170 you can fill in this box. So say okay, Dr. Sidra, up to 170 you can put it in this box. All good. So I hope that you learned a lot, and these are the important cases for exam. Your next session will be on cardiology role play. So you will get to see how to do role play on these cases. Prepare these cases so that you can do role play with me in the next session. If you have any question, you can always ask me at that class as well. Now, I can see that some of you are new here today. You might have some questions about our course. So feel free to ask it here. You can always ask it by unmuting yourself. I'll just allow that. But let us go through the course explanation again, that what's this course is going to cover and everything. Okay. So we'll go through the course video so that you can have a look, and still if you have any questions, feel free to ask it again. Just let me open that. Okay, so let us watch this video, which will cover almost all of the course related contents. And if you still have any questions, you can always ask it. Thank you. All right. So that's all about the course contents and everything. But also, like, there are a couple of other things which you might be able to get it from our website, which is the firstaidamc.com. You should be able to get into the course detail in a more detailed way in from our website as well. So if you have any questions, anything that you want to know, you can always ask it. Okay. Anything that you want to know about. So how long I will get access to the software? The course notes will be there until you pass the exam. The video access is for 10 months. So from the start of the course, you will get a 10 months of video recordings access, which means it's more than enough to even pass your exam in the 10 months time. Okay. And not only just that, you get access to our all the previous role play sessions, which has 75 videos so far. And the role play sessions means that the sessions that was taken by Dr. Cynthia, and that covers almost the last 3 years sample questions, which is extremely important for your exam. All good? So hopefully that should be all for tonight. If you guys have any questions, you can always reach us through the email or even inbox me. You are all in the Facebook group, okay? And I can see that some of you recently passed your MCQ exam also. So congratulations for that. And hopefully you will be able to ask questions in the future about the cages, because once you start reading, you start asking a lot of questions. So I'm looking forward to that. Have a good night. Thank you all for joining the sessions. Bye.